at this meeting, we have more mature data with the CAR T-cell therapies, and so we have an opportunity to compare and contrast and think about it some more. So I thought it would be worthwhile for us now just to take a look at all these different CAR T therapy details that we heard about here at ASH. And so I've just highlighted here some of the concepts that we heard discussed. And so abstract number 955, this is the follow-up of the Chinese study, and we will get into a little bit of detail about that. I think that that was a top priority trial here, many people interested in that. But some of the other interesting aspects, a fully humanized CAR T product. This has the advantage of the potential for safely administering repeated therapy, which, if that's the way forward, that could be useful. The allo CAR T is a CAR T that is potentially off the shelf. Is that something that could end up being useful? We don't know. Most of these CAR Ts right now are focused on BCMA, but there are other targets. One could consider using multiple targets, and as you know, some protocols are combination CD19 and BCMA. And so there are many ideas about strategies. Even the idea of the EGFR safety switch, I think, which is kind of a cool approach, the ability to shut off the CAR T cells if there's adverse side effects occurring. So all of these very interesting aspects for CAR T therapy. And so this is really the abstract that people wanted to hear the update, and so this is the so-called Legend trial, which is from China, and what we were hearing here at ASH is a follow-up of what we had heard at ASCO last year, when this was really a very unexpected and exciting study that was presented for the first time there. And so this is a particular type of CAR T. I would draw your attention on this cartoon here to the fact that this CAR T has a double head, so that there is a double attachment to the myeloma, and some would say that this is possibly a basis for potentially better efficacy, and certainly this is what's proposed by this Chinese team. What we heard results from today were results from one of the centers. Now, this product has been tested at 4 sites in China, as you can see here listed, and has been presented before. The results for 57 patients treated at one of the sites was what we heard presented here at ASH. And so this is what you saw, and I'll just summarize for our audience to see, well, what was it that we saw? Well, we saw some pretty striking results. 88% overall response rate, meaning at least a partial response, a 50% regression. But on your left, with the green bars, you'll see MRD negative, 74% complete remission, 68% MRD negative. So very high level of deep responses. Over on your right, you will see that the best response was not strikingly related to dose in this study. So that was interesting to see, nor was it particularly related to the BCMA expression that was studied. Not sure what happened there. I'm sorry, we seem to have lost the slides here for a moment. But we can continue to talk. But as they fix the slides, so this was the results that we saw today. And so what I was about to show you is what we had seen previously, which was the results with the BB2121 that were presented at ASCO this year. And so that the results with those, I would say, were somewhat comparable, or maybe a little bit less in terms of the response rate, which was in the 70s, and then also the median duration of remission, which was 11.8 months. What was about to show you here for the Legend trial was that the overall median progression-free survival was 15 months versus 11. But for MRD negative, the median progression-free survival was actually 22 months, which was actually rather good. And then the overall survival at 1 year was 94% actually. And so the remission duration and the survival was really quite impressive with the LEGEND data. So here we see the progression-free survival, as I said, 15 months overall, and then 24 months for the MRD negative. And then if we look at the overall survival 12 months overall, and not reached for the patients in the MRD negative status. And so really pretty impressive. And then I show you here the results with the Celgene product, the BB2121, with the 11.8 month median PFS. And so both are quite good. I would point out something that you guys are aware of, which is that there is a difference in the patient populations. Yeah. In the LEGEND trial, it was clear that the patients had fewer prior therapies, more in the 3 to 4 range possibly, whereas in this BB212 trial, obviously extensively previously treated with a median number of cycles of over 6, so that there's definitely that difference in the patient population to consider. So I would like to hear what we all think really about these therapies. Those two that we've just looked at would be considered the lead candidates in terms of potential approval. But what do we think about that? Is that the case? Do we think that those, one or both of those, might be approved? But with all of these new alternatives, where is CAR T therapy headed? I mean, those might be approved, but will there be new iterations that really end up being products that we will be using for the future? So maybe, Joe, you could comment first on this.
Absolutely. I mean, first of all, I agree with you, Brian. I mean, these are very impressive results. I mean, these are patients who right now, at least as we knew from the BB2121 study, who really had no other options left to them, who have that response rate. You're right. I think with the LCAR study that we see from China now, despite the caveats of there only being one site represented and it needs to be confirmed, they are a bit earlier stage patients, but that's impressive. 88% response, you know, over two-thirds of patients going into MRD negativity. So I think this is real. I think it's showing us the signal that this is a unique way to take down myeloma. That being said, I agree with you that, you know, if we want to stretch the car analogy, you know, we've got a great model car, but there are a whole lot of other benefits that we can add to this car, adding the sunroof and the stereo system and so on. I think what we're seeing are so many of these new advances that are probably going to make CAR Ts a little bit more effective and more safe at the same time. Right. So I'm not sure that these will be the final iterations that will go for approval, or perhaps they'll go for approval and there'll be subsequent ones. But I think there is more work. When I look at even just the last year and a half, how much safer CAR T-cell therapy has become and how much more effective we're seeing it, I think we've probably done the major manipulations, but there's still a little bit more to do.
Right. So how does this strike you, Mariby?
Yeah, no, I completely agree, and I think that so both maybe right now are the lead candidates to be approved.
Yes.
But I would say that this is the starting point to generate new CAR T cells, because so in these studies, so the T lymphocytes were not selected. The next step, and we have new CAR T cells in which so we are going to select central memory T cells in order to increase the persistence of the T cells. That I think that is incredible. But so anyway, I think that the results presented in both CAR T cells, I think that are really impressive. A bit better for LEGEND, but the patients, I think that are completely different.
Right.
And maybe in more developed countries, the patient population that we see everyday candidates to CAR-T, I think that are more consistent with the BB2121,
Yes.
exposed and refractory to first and second generation proteasome inhibitor IMiDs, and also to daratumumab. In China, the presenter said that daratumumab is not available, so
Right.
the patient population is different.
Clearly
But I think that
different, yes.
if we put together the data of both studies, so I think that the results are impressive, because so we are dealing with a patient population in which, so with the newer agents, that the median progression-free survival was not superior to 4 months, and now we are seeing here median progression-free survivals over 1 year. So I
Yeah, so
think
this
that
is
it's-
really an
yeah.
impressive difference.
I think that-
Several fold better than we've seen with other therapies.
And there had been that concern earlier on that maybe some of the CAR T cells will work and give a deep response, but then not persist.
Yes,
But
but
now I think we're seeing that.
we're
I mean,
seeing
to go
the
over a
persistence.
year and now 15 months, I think it's the proof of concept. We can do this. We can manipulate these cells. We can provide this. But I completely agree with Marie-V. I think it's really a starting point. It's by no means the end.
One development that people discuss is maybe it could be better if the cells are harvested earlier in the disease. So for the future, moving forward, CAR T cells, well, the T cells could be harvested at an earlier point, so that they would be in better shape for the engineering later.
Yeah, this is an interesting approach, because in fact we know that when we use the T lymphocyte at a late advanced stage of the disease, the immune system is less preserved and so is more exhausted. So I think that is an excellent option, as well as you mentioned, the allo CAR-T.
Yes.
This is another possibility, and so I think that definitely this is just a starting point, and so I think that we'll see new generations and new modalities of CAR-Ts.
Right. Okay, very good. So two very important immunotherapy approaches, quite promising for sure.
Yeah.